thrombocytopenia من الحاجات الكومن جدا في الرعاية اللي ممكن نتواجه بيها إن بيحصل نقص في الصفائح الدموية نتيجة تعرض العيان للهيبرين. طب إيه ده؟ يعني إيه الباثوجينيسيس بتاع الديزيز ده؟ إيه أنواعه؟ إيه التريتمنت بتاعه؟ في عجالة الهيت أو الهيبرين induced thrombocytopenia من الحاجات اللايف threatening conditions. ده immune mediated disorder characterized by two main features. One of them is thrombocytopenia. That means there is a significant drop in platelet count around 50% from the baseline. And the second is the hypercoagulable state. Hypercoagulable state means the incidence of thrombosis become increased, either venous thrombosis and arterial thrombosis, maybe DVT, maybe pulmonary embolism, maybe stroke, maybe MI. Plus the thrombosis in the peripheral vessels that lead to skin ulcers and skin gangrene. There are two main types of het or heparin-induced thrombocytopenia. One of them is called type 1, and it is the benign one. That means it means that the type 1, there is a drop in platelet count around more than 50% from the baseline, but without thrombosis, with no thrombosis occur. And the type 1, the most dangerous one. And sometime when we start to talk about the head, we mention type 2 in specific because it is the most life-threatening one and most important one. In type 2 heparin-induced thrombocytopenia, there is an immune-mediated reaction between the heparin and a protein called platelet factor 4 that cover the platelet. When this combination occurs, it starts to stimulate antibody formation against this complex, and this antibody formations lead to thrombosis and at the same time lead to destruction of the platelet and reticuloendothelial system that lead to thrombocytopenia after that. So the type 1 is the most important one that include thrombocytopenia and thrombosis elsewhere, either venous or arterial thrombosis. So what the pathophysiology of het or the mechanism of heparin-induced thrombocytopenia? Heparin-induced thrombocytopenia can be caused by multiple cascades. The first one is the combination of heparin and heparin platelet factor 4 that lead to complex between the heparin and the platelet factor 4. This complex lead to activation of the platelets, and when the platelet activated, there is aggregation of the platelets and the clumping of the platelets and leading to clot formation. At the same time, the platelets that covered with this complex heparin factor platelet factor 4 complex become destroyed, become destructed by the reticuloendothelial system as it is abnormal in form or abnormal in shape. So this leads to two components of het thrombocytopenia plus L thrombosis. Okay. When we start to diagnose this patient, how to suspect this patient? When we follow up a patient in the ICU or CCU, and this patient on heparin therapeutic or prophylactic heparin, the timing of het depends on the previous exposure of heparin. I mean that if the patient exposed to heparin in the past 3 months, so the early het can occur, the early onset around 24 hours. And we call this condition early onset het. But if the patient didn't expose to heparin before, so the onset become to start around 5 to 14 days. 5 to 14 days. Okay? This is the timing. The clinical picture that the patients come with is the drop of platelet count about 50% from the baseline, and thrombosis occur in spite of heparin therapy. And this is important clinical picture. Okay, when we suspect these patients, we undergo laboratory tests that confirm a diagnosis. The laboratory test that confirm a diagnosis is a test called antibody against the antiplatelet factor 4 heparin complex. This detected by ELISA or immunoassay. Antibody against the antiplatelet factor 4 heparin complex. Sometimes we assess the platelet activation in laboratory to assess the activation of the platelets in response to the antibody formation. This is the clinical picture, including timing, including a clinical picture that the patients complaining from either thrombocytopenia or thrombosis, and the investigatory tools that lead to investigations of HET. Okay, when we go to treatment of HET, or we start to go to speak about the treatment of HET, first of all, we should stop all kind of heparin immediately. Even when we suspect the HET, you should stop all types and all modalities of heparin. This is the first one. After that, we can go with the alternatives. The alternatives of heparin is called bivalirudin or fondopranax. Fondopranax is a type of heparin, type of anti-factor 10, but the incidence of HET very, very, very low. So we can use fondopranax in acute HET. The other modality, we can use L-bivalirudin or direct thrombin inhibitor in a dose of 0.75 milligram per kg as a bolus. After that, we can infuse this amount 1.75 milligram per kg per hour until the condition resolved. This is the first time. This is the first line, sorry, of treatment. What about Marivan or warfarin? We can go with warfarin until the platelet count become recovered. Because if we give warfarin in the acute attack, I think the thrombosis of the peripheral veins become more obvious and the skin gangrene or limb gangrene can occur. So we postpone warfarin until the platelet number recovered. As well as the platelet transfusion. We can avoid the platelet transfusion for fear of hypercoagulable state and the increased incidence of thrombosis. We can go with platelet transfusion only in life-threatening bleeding or in massive destruction of the platelets. After the platelet recovered and the number recovered to normal level, we can start anticoagulations to 3 to 6 months according to the plan of treatment of venous and arterial thrombosis. In short, these are the main points of heparin-induced thrombocytopenia regarding the definition, regarding the diagnosis, regarding laboratory tests that can help in diagnosis, and regarding management plan. First, stop all modality of heparin and all kind of heparin. Second, we can go with direct thrombin inhibitor, bivalirudin. We can start warfarin or platelet transfusions until the platelet recovered. Because warfarin in acute state can lead to skin ulcer, skin necrosis, and venous limb gangrene if it occurs or if it is given in the acute attack. After that, after the platelet recovered to the normal level, we can start anticoagulations according to the usual regimen of DVT and arterial thrombosis for 3 to 6 months according to the patient condition and according to the extension of thrombosis. Okay, this is in short the illustration of HET or heparin-induced thrombocytopenia. Thank you.